This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
The objectives for my 15 minutes are to first review the evidence for testing for clopidogrel resistance, which is a concept that's gained interest in the last few years, testing for genetic evidence of clopidogrel resistance as well as platelet activity testing directly, and then be aware of several of the new antiplatelet alternatives to clopidogrel. So as all of you are aware, clopidogrel, or Plavix, is a thionopyridine that's used by over 40 million people worldwide to treat or prevent atherosclerotic events. And it works by irreversibly blocking this platelet receptor that's needed for platelet aggregation. Its effects on the platelets last for the duration of the platelets' existence, which is about 7 to 10 days. Clopidogrel is a prodrug, meaning that it requires biotransformation through the liver to form an active metabolite, and this conversion process requires several sequential oxidative steps, and that involves several of the hepatic P450 enzymes. So clopidogrel resistance, it's defined by a high on-treatment platelet activity in the setting of receiving clopidogrel during in vitro testing, and it's fairly common. It's found in about a third of patients who are taking clopidogrel and associated with multiple factors that are also associated with subsequent cardiovascular outcomes, such as older age, higher body mass index, smoking, concomitant medications such as proton pump inhibitors, comorbid conditions such as diabetes and hyperlipidemia. But there's been increasing evidence that there is genetic variation in the clopidogrel effect in the population, with one of the genes, the CYP2C19 gene, accounting for about 12% of the variability in clopidogrel effect. And this works because in the oxidative steps, clopidogrel converting to its active metabolite, CYP2C19 is an enzyme that's necessary for that conversion before it then acts on the platelets. Wild type, which is star 1 here, indicates a normal clopidogrel response, so you get suppression of the platelet aggregation. There are a number of loss of function alleles, the most common of which is star 2, which is found in 10 to as high as 30% of the population, depending on ethnicity. But also several other ones from star 2 all the way to star 8. And the presence of at least one copy of these loss of function alleles is associated with clopidogrel resistance. In other words, you have high residual platelet activity. There's one allele that's associated with increased function, which is the star 17 allele, which is associated with clopidogrel sensitivity. So you have high platelet inhibition with a normal dose of clopidogrel. And in a meta-analysis looking at the association of some of these loss of function alleles with subsequent cardiovascular outcomes, they found that in people who had at least one copy of these reduced function genotypes, the star 2 to star 8, there was 18% increased risk of cardiovascular events. And when you break down the type of cardiovascular events, the significant one was actually stent thromboses with a 75% increased risk. So this association between these loss of function genotypes and subsequent cardiovascular outcomes led to an FDA warning in 2010, which warned about the potential reduced effectiveness in people who are poor metabolizers of clopidogrel. It informed healthcare professionals that there's actually a test. You can look at the CYP2C19 function, and advised you to consider use of alternative strategies or alternative antiplatelet medications in people you've identified as poor metabolizers. But it stopped short of actually telling you when to test or in whom to test. Despite that, there's been industry interest in developing faster ways of determining what someone's genotype is and whether they have one of these loss of function alleles. And in recent years, there have actually been several real-time or point-of-care genetic tests that can give you a result within, in the Spartan RX, 60 minutes after a cheek swab. It detects either the wild-type allele or the most common loss-of-function allele. There's another one I just saw that tests for 11 variants that takes 3 hours to run. So although these are not yet used in practice, I think you may be seeing more of these in subsequent months. Well, the question is, well, should you test for a genotype to look for clopidogrel resistance? Why not test directly for on-treatment platelet activity, which is in the abstract a more direct measure of someone's clopidogrel resistance? And there have been several analyses trying to find the association between on-treatment platelet activity and clinical outcomes. Probably the one to remember is in people that are undergoing percutaneous coronary intervention or stenting, coronary stenting. High on-treatment platelet activity, which they defined at a certain threshold, was associated with higher rates of myocardial infarction and stent thromboses. However, when they tried to look in just medically managed patients with a history of coronary disease or peripheral vascular disease, there was no association between platelet activity and cardiovascular outcomes. And that led to some speculation that perhaps active platelet inhibition with clopidogrel is more important during acute revascularization strategies or acute stents. And this is all qualified with the lack of evidence that there's no evidence that tailoring your treatment based on your platelet reactivity levels or aiming for a certain level of suppression actually makes a difference in terms of your clinical outcome. So still fairly early. There are several platelet function assays available. And they use various techniques to assess platelet aggregation. Common ones are there's point-of-care testing, such as the Verify Now, as well as ones that you have to send to the lab and look for platelet aggregation. One caveat is we don't really know what level of platelet inhibition truly correlates with clinical outcomes. And all of these different techniques, and even from machine to machine, may actually give you somewhat different results and varying ability to detect whether clopidogrel is active or not. So these are not yet clearly correlated with outcomes. So that boils down to, should we be testing? As of yet, there are no prospective studies that demonstrate there's a clinical benefit of trying to personalize your antiplatelet therapy based on either your genotype or your level of platelet activity on clopidogrel. And the most recent ACCF, AHA, and ACCP guidelines actually recommend against routine testing until there is more evidence that this benefits our patients. A lot of that is due to the acknowledgement that there is a potential burden and a cost associated with testing, but also knowing that there is increased availability of commercial testing available that you should be aware of, and several new antiplatelet therapies that are now approved. So the last part of this talk will be to review two of the alternatives to standard clopidogrel therapy. And these are Prasugrel, which is, the brand name is Effient, and Ticagrelor, which is Brilinta. Note that these are approved by the FDA only for unstable angina and non-ST elevation MI. So as of yet, there's no evidence in vascular patients or stents in other vascular beds. Prasugrel is related to clopidogrel. It's a thionopyridine, but it has a faster onset of action. It's more potent in terms of its antiplatelet effects, and it doesn't depend on that CYP2C19 enzyme, and so bypasses the genetic variability. It's dosed with a loading dose of 60 milligrams followed by 10 milligrams daily. And in a randomized trial looking at clopidogrel versus Prasugrel in people with acute coronary syndrome undergoing percutaneous intervention, They found that Prasugrel had about a 20% lower risk of the primary endpoint, cardiovascular death, MI, and stroke, but at the expense of an increased risk of hemorrhage. So more effective, but more hemorrhage. In medical patients, however, there really was no significant effect. So this is a second trial that was looking just at medically managed acute coronary syndrome patients, so not individuals who are undergoing stenting. And even though Prasugrel was associated with greater platelet inhibition, at least at 30 months, there was no difference, statistically significant difference in the primary endpoint of cardiovascular outcomes, and there was no difference in terms of hemorrhage. So maybe this is more important in the acute stenting process. Prasugrel, so in summary, you can consider using Prasugrel for acute coronary syndrome in people who are undergoing revascularization. Understand that it's maybe more effective, but you have to trade off with a higher risk of bleeding. It doesn't seem to have an advantage thus far in medically managed individuals. And a couple cautions about Prasugrel. If you're going to prescribe it, you should be aware that in patients who were 75 or older than 75 years or of low body weight, there was no net benefit. And in people who had a prior history of stroke or TIA, there was actually an adverse rate of intracranial hemorrhage as well as no benefit. So avoid it in people with a prior history of stroke, TIA, and may have no benefit over Clopidogrel alone in older patients or those of low body weight. Ticagrelor is the other FDA-approved new antiplatelet agent, and it's a direct-acting inhibitor of this platelet receptor 12 with a faster onset of action and a stronger platelet inhibition than Clopidogrel. It's dosed with 180 milligrams loading dose followed by 90 milligrams BID. And in a study that randomized people to Clopidogrel versus Ticagrelor in those with acute coronary syndrome, again, you see that Ticagrelor is more effective than Clopidogrel, about 15% reduction in your primary endpoint at 1 year. And then it depends on how you look at major hemorrhages, but there probably is a slight increase in serious major hemorrhages. So Ticagrelor, you can consider it for people with acute coronary syndrome, and similar to Prasugrel, it may be more effective, may have a higher bleeding risk. The caution with Ticagrelor was that in subgroup analysis, Ticagrelor didn't seem to have any increased efficacy over Clopidogrel when given concomitantly with over 100 milligrams of aspirin. And looking a little bit further into that data, this is largely individuals in the United States. So it's unclear whether it's an aspirin effect or a center effect, so that people in the United States didn't get increased benefit with Ticagrelor. But it is an alternative agent that you might consider. So how do you all put this together? So you should be aware that Clopidogrel resistance is maybe associated with worse cardiovascular outcomes in people undergoing coronary stenting. You can test for Clopidogrel resistance with genetic tests, with platelet activity tests, but as of yet, it's unclear whether tailoring therapy based on your test results actually makes a significant difference in clinical outcomes. And so for the large majority of patients, routine testing is not currently recommended. There are some higher risk patients that you could consider testing. And again, these are individuals undergoing coronary revascularization who may be at particularly high risk. So those with extensive or complex lesions or multiple stents, or those with a history of stent thromboses. And if you do decide to get a genotype on these high-risk people, you'd be looking for people who have at least one, but probably at least two copies of one of these loss-of-function alleles. And those are the individuals that you may consider using an alternative antiplatelet therapy if you have no contraindications to their use. And those alternative antiplatelet therapies you have are Prasugrel and Ticagrelor, which seem to be more effective in terms of reducing cardiovascular events, but have a higher bleeding risk. Note that these are, again, approved only really for coronary artery disease. There's some ongoing trials that are investigating their use in peripheral vascular disease, but for now, this is limited to coronary disease. So thank you for your attention. Appreciate it.